Hello, good evening.
Hello, Mazen. How are you?
I'm fine. How are you, Professor? Everything is fine?
Everything is fine, thank you.
Nice meeting you again.
Very nice to see you.
Thank you
This is
very
going to be
much.
the last lecture for me.
In the series, for
Yeah.
you, yeah, but in this series only, and we will invite you as well for the 2022 series as well. We are preparing now. It will be our pleasure to have you again.
How kind. Thank you so much.
Thanks to you, sir, because your presence is an honor and we have learned a lot from you. Great. Still, we have 3 minutes and
Okay.
The audience are getting in.
Mm-hmm.
How is the weather now in London?
So it's variable. In England, you can get all 4 seasons in one day. And this
Yeah.
morning was raining very, very hard, but it seems to have gotten a lot better now. And of course, today, is it Halloween today?
I think tomorrow.
Oh, okay. That's good. I'm
Tomorrow
hearing some
night.
fireworks already.
Uh-huh. The weather here in Dubai is getting much better than before.
Oh, yes.
Now it's, let's say, in the 20s degrees centigrade. So it's nice to walk.
So no need for air conditioning then?
Still we do, but let's say that not as hot as before.
So I'm ready to start whenever. And can you enable me to share screen?
Yeah. Done.
Okay.
Perfect.
Well, good evening. My name is Christopher Liu, and the title of my talk this evening is Early in the Morning. And this refers to recurrent corneal erosions, which happen early in the morning or in the middle of the night when people wake up. Here in the morning, we have the Bee Gees song from the early 70s, one of my favorites. Recurrent erosion syndrome was first described as early as 1872, and initially it was termed by the author as intermittent neuralgic vesicular keratitis. And you can understand that obviously the keratitis affects the cornea, and vesicular means that you can see little bubbles on the surface of the cornea. Recurrent corneal erosion is a chronic relapsing disease of the corneal epithelium characterized by repeated episodes of corneal deepithelialization. The diagnosis is relatively easy, and there is a typical symptomatology, which is pain and watering on awakening or in the middle of the night. And that kind of gets better after a few hours, apart from more severe cases, which can take much longer to settle. And they may well be a history of injury. And typically there are 4 types of injury, which gives an abrasion, which tends to give rise to longer term problems of recurrent erosions. These are tree branch, paper etch, child's fingernail, and hairbrush. Now, look out for laterality and family history as well. If it's in both eyes, it's more likely to be due to an underlying dystrophy, corneal dystrophy. At slit lamp examination, you may find a frank epithelial defect or a large area of edematous non-adherent epithelium. An application of neat fluorescein is necessary, and sometimes you need to put another drop in or even a third drop to stain it properly. And one of the staining is not really to look for denuded area, but because part of the epithelium may be swollen and raised, the fluorescein can go around it and surround it like a fluorescein surrounding an island in a map or on the sea. I'll show you an example. Then afterwards, use a broad angled slit beam and retroillumination examination after dilatation of the pupil to define the whole extent of the lesion. Sometimes when you have to remove the epithelium, which is loosened, you realize that there's a large area which will come off with it, and we'll go into that later. It is really important to look out for infection. So look for stromal infiltrates, cells in the anterior chamber, and any hypopyon. So I have seen patients with recurrent erosion and the eye was padded. So the temperature is actually higher when it's padded, and overnight, what was a mist infection became a frank Pseudomonas infection. So it is really important to look out for early infection, and also probably best not to patch the eye because you are actually raising the temperature unnecessarily. If you're not sure whether the area is loose, then you can use the cellular sponge and see whether it moves around or not. So it is important to examine the fellow cornea for signs of dystrophy, like map dot fingerprint. And lid eversion, of course, that is always an examination, part of the external disease, which is often missed out because it's troublesome to evert the lid, but it is essential to do so. Here you see a clinical picture, and here is an area of recurrent erosion. And on staining with fluorescein, some of it did take up a stain. As I said, it's important to put in neat fluorescein, sometimes more than one drop, and it's either in this form or you wet this kind of florets with saline and apply it onto the lower fornix. Here are a pair of pictures from Steve Whiffin's website, and you can see that there is an area of recurrent erosion, and you can see also how it's stained. Now, there are some areas which are stained, but look at these raised areas. They actually appear darker and not have any pooling of fluorescein. So when you have these raised areas, like an island or little hill or mountain, then the surrounding fluorescein will make it stand out, and you know that there is a raised epithelium here. How does it come about? Well, reattachment of the corneal epithelium after an initial abrasion seems to be defective in cases of recurrent corneal erosion syndrome. There may be underlying abnormalities in the epithelial membrane, a basement membrane, and its associated filament network, in particular, weak hemidesmosomes or weakened hemidesmosomes when the epithelium is covering the stroma, but the hemidesmosomes have not formed properly, so it's not adherent properly. The primary causes are various sorts of corneal dystrophy, in particular, map dot fingerprint, but any of these stromal dystrophy can also have recurrent erosions. Secondary causes, trauma, the most important, but also a mechanical trauma, but it could be other sorts of trauma as well, as infection and diabetes, ocular rosacea, Stolz-Benoit, band keratopathy, dry eye, and even epidermolysis bullosa. So it's important to note that patients with a traumatic etiology are more likely to suffer from chronic episode than those with epithelial basement membrane dystrophy, because these patients have an inherent weakness in the basement membrane and adhesion. But don't forget that patients with an underlying basement membrane disease are more easily traumatized as well. So just because there is a history of trauma, it doesn't mean that they do not also have epithelial basement membrane dystrophy. So other features which you may notice, there is a high incidence of meibomian gland dysfunction, and where there is epithelial loosening, there is an elevated level of matrix metalloproteinases, in particular MMP2 and 9. And there may be some mutation of interleukin genes and collagen and so on. So you've made a diagnosis. How do you treat an acute erosive episode? Well, at the time of examination, you're already dilating the pupil in order to use the red reflex to examine the cornea more carefully. So you can continue with cycloplegia to reduce the pain of the acute erosion. Where there is an epithelial defect, then you want to cover with topical antibiotic, eye drops by day and ointment by night to reduce the risk of infection. But at the same time, these antibiotics are also acting as lubrication both by day and by night. Once the epithelium is healed and settled, then you can switch to preservative-free artificial teardrops during the day and a plentiful of bedtime ointment. I say a big dollop, that's a colloquial term, meaning a very large amount. You're smothering the eye, so there is no chance that the back of the upper lid can adhere to the epithelium and ripping it off again overnight, because there's decreased tear production overnight. And you need to continue with lubrication for 3 months when the patient is symptom-free. In other words, there is no tearing and no pain for 90 consecutive nights and mornings. If there is an acute erosive episode, then you have to start the clock again, because it is estimated that it probably takes 3 months for hemidesmosomes to form properly. It takes a much shorter time in rabbits. We don't really know how long it takes in human beings, but we postulate that 3 months should be sufficient. Also, you might instruct the patient to open the eye carefully and slowly on awakening and wait for the eyes to become moist before doing that, because the eyes are drier overnight. Patching, not really recommended, and bandage contact lenses, I don't really use in my practice for recurrent corneal erosions, and I'll tell you why. I haven't really found them very helpful at all. So this kind of ointment you might use is non-medicated once the epithelium is healed and settled, and you do have to use a very large amount. This used to be called Vitae-Pos. So if you look at the anatomy of the orbit in sagittal cross-section, if you pull down the lower lid and put ointment in there, it can only contain so much, and the rest is spilled over. However, if you have the patient lying down and pulling the upper lid up, and with the patient's eye looking down, you will actually find that you have a huge cave here that you can put a large reserve of ointment at bedtime, so it lasts a whole night, and the patient doesn't have to worry about having to top up on, or there not being enough ointment. So remember, it's an ointment and not a cream. An ointment is grease-based and it lasts a night. So let me tell you about therapeutic contact lens. That's the technical real term, but often people call it a bandage contact lens. So if you're minded to use this, it is acting as a splint to help the epithelium heal. And one example you can use is the silicone hydrogel plano. But on the other hand, any contact lens will do, but you do need to check the fit once it's equilibrated on the eye environment after 1 hour and after 24 hours. Now, ordinarily, when you fit a contact lens, then with each blink, it can move up to 1 millimeter. But because you're using a contact lens as a splint, you want it to move not very much at all. So there should be very little movement when blinking. And also the other thing that you should look for is whether the limbal vessels are blanched. Now, if they're completely blanched, it means that the therapeutic or bandage contact lens is too tight. You should have a blood flow to the limbus. Now, remember, these lenses are worn day and night, so technically extended wear. So it does put the patient at risk of infection. In the United States, they will use a topical antibiotic as prophylaxis. In the UK, we tend not to use this sort of prophylaxis. Now, the question is, when you have a period of calm, when do you remove the contact lens? Well, probably after about 6 weeks, although you may have to change it from time to time. And remember, even when the corneal epithelium is splint under a tight contact lens, tightish contact lens, it is still possible to have a recurrence under cover of a bandaged lens. And also remember that it is not possible to examine the cornea fully in the presence of a contact lens because it's going to hide a lot of things. So you will need to remove the lens and look with all sorts of lighting directions and fluorescein stain and so on. Well, what are the other problems with a therapeutic contact lens? Well, firstly, there are patients who cannot tolerate a contact lens. And secondly, in an early study, patients lose a lot of contact lenses. So when they come back, you don't see the lens anymore and you wonder where it's gone. Okay, so that's therapeutic contact lens. Lots of people use it. I haven't found it useful, and it really is not necessary because there are other measures to be used, mainly lubrication. So what are the other adjunctive treatments then? Now, doxycycline has been shown to reduce metalloproteinase MMP9 in unstimulated corneal epithelial cultures up to 70% reduction. So we do know that if you need to, you can add doxycycline and it can help with the healing. So a combination of oral doxycycline and topical steroids can be used successfully in recalcitrant cases as well. Benzodiazepines, which are usually used as sleeping tablets, they are not used very much, but you can also imagine benzodiazepines abolish rapid eye movements or REM sleep. And if you stop the eye movements in the middle of the night when there is not very much tear production, you may also reduce the risk of recurrent erosions in some cases. Now, if recurrent erosions last for a long time because they're not properly treated, and sometimes patients come to see me and they're really, really distraught and they think, gosh, it's been going on for weeks or even months and their eye doctors have not managed to sort it out for them. And I tell them, don't worry, it may take more than one visit, but I will get you sorted and provide them with hope and support, and also explain to them that it won't get better instantaneously, but it will be resolved with proper care. Now, topical anesthetic drops, generally undesirable, but on the other hand, if it's very painful, then it does give the patient some relief for a short time. So when do you need to go on to surgical treatment then? Well, these are for recalcitrant cases, and that means recalcitrant means a non-healing acute erosive episode, or it's healed, but it keeps coming back and you have to do something about it. Well, the simplest is epithelial debridement, and you can do that just with a sterile green needle, hypodermic needle. And as I said, If you have really loosened epithelium, even though it's continuous, it is not an aesthetic because there's a lot of MMP and inflammation. And by the time you take it off, you realize that the surrounding epithelium will also come off with it. So you have to remove that as well, but always leave a healthy rim of limbal tissues and peripheral epithelium for it to regenerate. Okay, so another thing you can do is anterior stromal puncture. And the rationale of that is that you break Bowman's membrane and cause a little bit of scarring. And also the area that you've punctured or scratched will allow an epithelial plug to grow in when the epithelium grows back, and that improves the surface area for hemidesmosomes to form. A relatively new technique is alcohol delamination of corneal epithelium, or ALD, or ALDCE, and we'll go into that. That is also an effective way of helping recurrent erosions heal and reduce the risk of it coming back. Then you have phototherapeutic keratectomy, or PTK, and that is done with an excimer laser. And I'll tell you a little bit more about that. So I don't do superficial keratectomy with a diamond burr, but for completeness sake, I will tell you about it. That basically you use a very fine diamond burr to remove the epithelium and to polish the Bowman's membrane, leaving 1 millimeter of intact perilimbal epithelium. You don't really want to scar Bowman's layer, so it needs to be very gentle, but I don't think actually we need to use a diamond burr at all. So the next thing is anterior stromal puncture, and that is done with a bent 25 gauge needle attached to a syringe. And then you put multiple superficial punctures approximately 0.5 millimeter apart in the affected area and also slightly beyond. And you can check where you've punctured by putting some fluorescein in. Now, what I found is, since this was described over 20 years ago, I found that it is possible to just use an unbent green hypodermic needle. There is no need to bend it. And actually, there is no risk, hardly any risk of puncturing, because if you use the sort of pressure that you need, the cornea will actually indent and it will not puncture. Also, it is not necessary to do perpendicular punctures. You can just do superficial scratches and they work just as well as punctures. You will see some scarring, but it is just like the scarring from PRK, that it gives the scatter backwards, so the examiner, the ophthalmologist, see the scars, but the patient is not affected by these small scars. So at final follow-up, over 60% of eyes are symptom-free, according to Zauberman. In my own practice, it's at least 90% effective. I'm talking about anterior stromal puncture, or ASP. So here you can see the puncture marks, and you need to go beyond a little bit outside the area of affected where the epithelium is raised. So you can also do stromal puncture with the YAG laser, but whilst it was described previously, this technique is no longer used. It doesn't help at all beyond the use of a green needle. So why do something more complicated when you can do it simply with a green needle? So we move on to phototherapeutic keratectomy, or PTK, and this is definitely an effective procedure for treatments of acute erosions and also prevention of further erosions. And the reported success rate range from 60 to 100%. And PTK is more successful for post-traumatic recurrent erosions rather than as a result of corneal dystrophy. However, sometimes people will advocate PTK for corneal dystrophy because a large area, including the central cornea, needs to be treated, and it is thought that PTK will create less scarring than your stromal puncture. So the surgical technique is you remove the loosened epithelium right up towards the limbus, and followed by application of a very small number of pulses to ablate to Bowman's layer to achieve ablation depth of just several microns. And a large diameter is useful because if you do a small diameter, then and you can create some astigmatism and some hyperopic changes, it would reduce the patient's quality of vision. So the change of refraction, generally a hyperopic shift following PTK. There is a trend of hyperopic shift, and except O'Brien found a small myopic shift, and Bertie Sides et al. Found no significant changes in central keratometric power after PTK, as long as you don't ablate more than 5 microns of stroma. So let's move on to alcohol delamination of the corneal epithelium, or ALD. So this is used for recalcitrant recurrent corneal erosions. And in this particular study, 11 of 12 eyes of patients had dramatic relief. How is it done then? Basically, it's almost like PRK when you remove the epithelium with 20% alcohol, but of course there's no laser necessary. So you use a well, and then you pour in the 20% alcohol, and you wait, and then you irrigate with BSS, and then you debride the epithelium completely, almost as a single sheet, and then you put a bandage contact lens in place to help splint the healing epithelium and also to reduce pain. It is actually very efficacious, and it's ranked equally with PTK and ASP. Obviously, with ALD, you don't need an excimer laser, so it is much easier to perform and cheaper as well. The reality is that the Cochrane review on RCES treatment concluded that we would need to use well-designed masked randomized controlled trials using standardized methods to establish the benefits of new and existing prophylactic and treatment regime for recurrent corneal erosion. I have described all the modalities to you, and I will give you a summary shortly. So firstly, prevention is better than cure, and this is at 2 levels. Firstly, reduce the risk of injury with eye protection. And secondly, and this is not proven, consider that you have a corneal abrasion as a result of the 4 famous offending agents like a child's fingernail or the edge of a piece of paper or tree branch or hairbrush. If you have that, why not, after the epithelium has healed, why not give them day and night time non-medicated lubrication for 3 months? Maybe that would help it heal properly and avert the need for future treatment, because we may have prevented recurrent erosions altogether after that sort of trauma. And remember, secondly, that the mainstay of treatments is prolonged lubrication day and night, initially with antibiotic cover. And the prolonged treatment is for, let's say, 90 nights and 90 days, when the 90 nights and 90 mornings will have to be symptom-free. If you get an acute erosive episode, you're going to have to start the clock again. Now, in recalcitrant cases, I've told you that I don't really depend on a therapeutic or bandage contact lens very much. I'm quite ready to use anterior stromal puncture, which is of equal efficacy to alcohol delamination. And PTK, to be honest, I've never really needed to use that because I don't think that With ASP, it causes much scarring, which the patient will notice. So even for dystrophic cases, you can still use ASP in the central cornea. And remember, TLC stands for tender loving care. For those who need psychological support, then give them the hope and tell them that it will be sorted out. And because you now have a method and you know how to sort out these cases, even though it might need some time. So adjuvant treatments, you have anesthetic drops in the very, very short term. Steroid drops are helpful in the short term. Oral tetracycline can be added. And this is actually very, very helpful in cases which won't heal or which keeps coming back. Oral benzodiazepine to abolish rapid eye movement sleep can be useful in some cases. The cases which wake up in the middle of the night rather than those in the morning, they may be related to rapid eye movements or REM sleep. Botulinum toxin, I haven't really gone into details of this, but if you read Ian Mackey's paper, then it will describe how it is useful. So now I hope that the equilibrium and the beauty of the morning can be restored. And here's one type of morning glory flower, very beautiful. And here's morning glory vegetables, and very prevalent in Vietnam and also in China. And cooked with chili and garlic is very, very tasty. There is, of course, the morning sky. Here's the sky from my house. One morning I saw this and I took a picture of it. And also you could be in India very early in the morning before everybody comes and take a nice picture. Thank you very much for your attention. And if you wish to contact me for whatever reasons and questions, then I'm available on these email addresses.
Thank you very much, Professor. Actually, it was very nice lecture. It was wonderful as usual. Although it is concise, but it was direct to the point, systematic, and very academic. Thank you very much. Now,
good evening, Dr. Mazen. Good evening, Professor Liu.
Good evening, Dr. Nancy. Thank you for joining us. Now, actually, what I do, similar exactly what you have mentioned. In addition, I discuss with the patient the AC and the airflow, especially during sleep, because in our area we have to use the AC during sleep because it's too hot. So I always discuss the whether the AC is directed directly to the bed, then either to change the direction of the AC or to change the location, the position of the bed of the patient. I always discuss as well whether the patient has an open eyes during sleep, the gazelle eyes, because it has a role. So what do you think, Professor?
Yes, I think anything to avoid drying the eye, drying the eyes is useful. So you got your AC, and of course, if there is any nocturnal lack of thermals, that also needs to be addressed as well.
Yeah, thank you. Dr. Nancy?
Yeah, I was talking, I'm not sure if I'm heard well or not.
You are now.
Is my now,
yeah,
okay.
We can hear you.
Yeah, I think every single piece of information Professor Liu has mentioned is very valuable, especially the part where we should address the patient's psychology, because they come with more morning pain, and they're sometimes in so agony they're not able to digest that they will be okay eventually, even though the first initial treatment might fail at the beginning, but we have to go stepwise. And at the end, as Mr. Liu just mentioned, they will go through this. And our role is to minimize the incidence of another abrasion or another erosion. One point I might be questioning in my treatment of recurrent erosion is the use of an ointment. I have this theory, let's say, or kind of point that if I use an ointment on a braided cornea or a cornea that is a sloughed epithelium, I am mechanically overweighing the new cells to bridge the abrasion or the gap, and I'm making it. Although I'm lubricating it, I'm making it difficult for the palisading cells coming from the limbus, let's say, to cover the gap. So I usually abstain from using ointments. If I want to use something that's viscous, with a low weight rather than a high weight like an ointment. It's just something that I use in my practice and I thought of mentioning.
Yeah, great, Nancy. Actually, what I'm using is the petroleum oil ointment. I found it very, very helpful for the patients. It's very, very thick, and but today I learned from Professor Lou that it's better to teach them how to put it in the upper fornix rather than the lower fornix, because the bulk will stay in the eye during sleep.
Yes, absolutely. And I think it's in the upper fornix because as the upper lid just pulls out the outer layer of the cornea as it opens in the morning, it's like the shutter effect. You minimize it by making the surface slippery.
Mm-hmm. Beautiful.
Yes, so
Thank
it is the back of the upper lid which sticks to the epithelium. Yes. So using the upper fornix not just has a larger volume, but also it is the exact area that it needs to be at. With regards to oil-based or water-based, I do think that an oil-based one will be better. I mean, it takes it lasts a much longer time. And I understand your fear that it might retard growth or even get trapped under the epithelium, but that doesn't actually happen. So maybe try and see, try on 1 or 2 patients and see what you think.
Yeah.
Shall I try and answer some of those questions then?
Yes.
So vitamin A drops, I haven't really used, but the hyaluronic ointment, it actually used to be called Vitae Pos, and it does include some vitamin A. Regarding how long to keep a TCL, therapeutic contact lens or bandage contact lens, normally you have to change every month, but some studies say you can remove it after 6 weeks. But as I said, we don't know how long it takes for the hemidesmosomes to form. It probably takes longer than 6 weeks. And very true, you will get hypoxia even with the best contact lens. So and also you need to wear that overnight as well when the lids are shut. So there's even more hypoxia. So that's why I don't really like putting a bandage contact lens in place. But it is very common practice. I don't like it. Regarding topical steroid, I think actually you only just need to give it a blast to switch off the inflammation. And again, I don't use it very much, but when I have to, then it's really just for a few days, no more than a week. In terms of autologous serum and amniotic membrane, that we're moving into territories which are much more complex and expensive, and in my view, unnecessary. So I think the tools that I've described will heal more or less all your erosions. There's no need to take blood and spin it down, and also with amniotic membrane, it's also expensive, and it's again just like a therapeutic contact lens. It stops you from examining the cornea unless you apply it like a contact lens. that is also fine, but expensive and unnecessary in my view.
Okay, great. That's it. Thank you very much, Professor. Okay.
It's a relatively small topic, so I think that's all there is to say about it, really. I'm sorry, it's not an hour.
Oh no, thank you very much. And we don't want to delay your dinner as well, because always we choose this time, disturbing your dinner.
I'm going to have Kentucky Fried Chicken this evening.
So it's like a free meal today.
Yeah.
I mean,
KFC.
not free. Yeah, I mean by free that it is not house-made.
No,
Yeah.
Gonna take a break and just go to the shop to buy fried chicken.
Yeah, this is what I mean by free. I mean break. Okay, great. So happy appetite, Professor, and thank you very much for everything you taught us. It was amazing, actually, your participation in this series. And of course, you will stay with us until the end of the series, and we will have you as well. We will be honored to have you in the 2022 series as well. So thank you, everybody. Thanks, Dr. Nancy. If you want to say something, Dr. Nancy or Professor Lou, before we end.
Thank you, Dr. Mazen, for bringing or putting this together, actually.
Yes, and thank you for involving me. Everybody have a lovely evening.
For you too. Goodbye.
Bye-bye.